very emotional today to lead this session when seeing these wonderful projects and ideas where we have started and where we are today. And you can be very proud with the whole team what you have achieved. And we come to the next speaker. Dr. Marta Ca. She's also a neonatologist in the La Paz University Hospital in Madrid in Spain. Marta Ca. is the Breastfeeding Hospital Initiative Coordinator for the neonatal units in Spain for protecting, promoting, and also supporting breastfeeding for the small and sick newborns since 2019. She is also working in the family integrated care, so in the IIIC program, not only in Spain, also internationally in the working group. And she works on the economical, but also on the culture side. So it's important to have you here, and here also another program which also made a lot of changes in the last year. Thank you for being with us.
Thank you for your nice presentation. I'm happy to have the opportunity to present you our project of family integrated care in a 3-level neonatal intensive care. As all of you know, and also Santi expressed, current situation in some places is that care is done by healthcare professionals and parents are welcome, but not the structured participation in the care of the baby is done. So the philosophy of integrated care is that parents are invited to learn and participate in the care of the infant independently of the clinical condition of the baby. And they were, in the FICARE model, parents are considered as primary caregivers at the NICU, and the position of the healthcare professionals are facilitators in this progress of being parents. With that, which is the worldwide evidence of the first hospital who started with the mother-baby unit in Estonia, because they don't have enough professionals to take care of the baby, and they report a better weight gain. Then we have the study of Toronto, the group of Karen O'Brien. They start to do family integrated care in intensive care with CPAP respiratory support, and they report higher breastfeeding at discharge, higher weight gain, and reduced anxiety and level of stress in mothers. Then they conduct an international clinical trial and see that it's feasible to start FICARE integrated care in this unit. And we are scaling up to a 3-level NICU, and then I'm going to present you an international project that we are involved. So the benefits for patients are better weight gain, better breastfeeding rates that are all related with the neurodevelopment, less nosocomial sepsis, less of hospital stays, and less adverse events. And for family, less depression, less anxiety, and post-traumatic stress that are very important for the bonding and to be parents with their children independently of the sick that they were. And for healthcare professionals, reduce burnout and reduce work insatisfaction in those units that we are with many stress situations. So the pillars of care from the group of Toronto, the first one is training the staff and change in attitudes, skills, expectations, perceptions, and behavior of professionals, families, managers, and society. And this is one of the most difficult things that we are looking actually. The second one is training and participation of parents in all the procedures and continuous evaluation of their progress and difficulties. This is an easy part of the program. Parents are very, very involved, they are motivated, and it's a pleasure to work with them. And the next pillar is psychological support for parents. They are living a very stressful situation, so the intervention of a multidisciplinary team is required in addition to veteran parents. And the last one is related to the environment. Adequate physical environment in the neonatal unit will be defined with policy and process adequated. So we know that from the European Standard of Care for Newborn Health, from the IIIC, and also for the WHO Association, that the institution must provide family-centered care support by a supportive environment, making it easy for mothers and their newborns to stay together and practice routines in a 24 hours per day. So we conduct this study to scaling up the family integrated care model in a 3-level unit, with the challenge that we don't have rooming in that moment. So for us was a challenge, and we decided to do it. So We recruit patients from the risk pregnancy department, from the NICU, from the stable ward, and we ask for information, for informed consent for the families, and if they want to accept to participate in the program, we give them all the information and the learning material. So our first inclusion criterion for this pilot was the birth weight for the baby, birth weight at lower or below 1,500 grams, or gestational age lower than 34 weeks, and other perineonatal condition anticipated NICU specialized care, admission for at least 7 days, and decision to provide full support. And the inclusion for parents, where parents age more than 18 years, willingness to spend at least 6 hours per day at NICU, or commitment to attend educational sessions. Active involvement in care for their infant at least 7-day periods, not in the language barriers to understand the material. 1 primary caregiver is involved in training and sign informed consent. So how I tell you, we didn't have rooming. We have this kind of the left. Imagine with an open ward, the incubators are near one by the other with a space for a sofa. But we count with a family room from Ronald McDonald Foundation. Is the one that is inside on a hospital in Spain, and give us the opportunity for parents to cook, to have lunch, to can have a shower, can have a lock. Also, they can take a nap. They can bring their other relatives, the other babies, and make homework. So for us, it was very helpful to have this facility. We are a 3-level unit, intensive care unit with all the pathologies, with cardiovascular surgery, extracorporeal membrane oxygenation, and all the things that you see in the slide. So we established this kind of strategic plan. First, we make a co-creation process and develop of teaching materials from 1 year. Then we make a dissemination at the NICU staff training in 3 months. Then we start piloting, and now we are generalizing the FICARE program. Our co-creation progress, we make a textbook with learning concepts, also in PDF, and a register activity book for parents to take all the things that they want, the monitoring the baby, they can make a painter, they can write their feelings, it's like a diary, and we have accreditation checklist that I will tell you how it works. For us, very important, the steering committee, or there was the healthcare professionals and parents. This steering committee are done by doctors, nurse assistants, psychologists, social workers, therapists, veteran parents, and others are the core of the FICARE program, and we call them FICARE champions. These people are the ones that are going to have the role of country implementation team, and are the ones that are going to train the other professionals. So very important to have not only a leader, but also an implementation team. For the second part, we made the dissemination at the NICU staff training in 3 months, and we train 90% of the professionals. From the FICARE teams, we have some nurses. Each nurse teach 10 other nurses and was the mentor or the reference for any doubts or questions. We have like a training map, some for professionals and some for families, but finally are almost mixed. For professional staff, we have the introduction to the model. We have important chapter related to communication abilities, bonding and support, which are the psychosocial necessity of the family, conflict resolution and mourning, and of course a chapter related with self-care. For the families, we'll come to the program, presentation to the intensive care unit, physical and functional, how we are doing that, bonding and communication, professionalized parents, and self-care also for them, and then the transversal area related with pain and stress newborn, neurodevelopment of the newborn, and prematurity. So for parents, when we start the piloting, they receive the theoretical support. They also have workshop outside, 1 per day, and also they have tutorized sessions outside with the nurse. So training process, they have the opportunity to read the learning material. They have to observation and recognize their baby in between with the nurses. They join work with nurses to transition to theoretical and practical concepts and make empowerment in care, be autonomous in care, and they take the accreditation. So this is an example that a mother with the first time that he taking kangaroo her baby, thin baby, less than 1 kilo, then start reading the monography in kangaroo, then at the intermediate case, she does everything for her baby, and then a photograph that she sent me from home. We decided to make like a opportunity match. That means the parents have the opportunity to ask by themselves, what can I do for my son? What do I want to learn and want to implement today? When is the time? Not all the moments are the better moments. So we have to be very respectful of the needs of the newborn and the wishes of the parents. We realized that there will be some patients that can be only in the basic training level and other in advanced training level with invasive support respiratory and not invasive. Also, we have bladder catheter, ostomy, wound care, inhalation procedures, and also we make a training map according to gestational age. So one of the best things that start to doing when we run out the program is the tutorial sessions. Those are met cost-side, and it's individualized teaching plans for tasks adjust to the clinical condition of the child and the wishes of the parents. Each instruction will be carried out as described in the textbook. Parents could be accredited more than one task at the same time, and there is no order to acquisition of the accreditations, although we have some recommendations. This is an example of our calendar per month with many things are done from the Parents Association, also for the speech therapies, occupational therapies, also impact of prematurity for psychologists, colleagues, stress and anxiety, monitoring, home care, cardiorespiratory resuscitation when they are going to go home, and micro and macro ambient. Many things to learn. Parents, at the beginning, we made that in the classroom, but then we made outside because of the pandemic, and we realized that it's better because parents can stay with their baby. So this is an example of a couple that is taking care of their own baby. It's a very severe bronchopulmonary dysplasia with a tracheostomia, and they are recording things from the baby. They are taking care of the fluids, and they are weighing the baby by themselves. This couple are almost autonomous, and they have to be because they are going to go home with the tracheostomy. So this is another example of participation of males. The left one is a parent that is learning how to make wound treatment in the skin because it's an epidermolysis disease, and he has to take care of that at home also. So she is learning just from the beginning how to do it with very careful way. And the other is a very proud man with doing kangaroo, very happy to be there. So the determinant aspect of the FICM implementations were involved of the service, entire service. It's a strategic project. We also, full adherence to the procedures, rigor on the methodology, open and empathetic communication, harmonized instruction from professionals and parents with a specific itinerary, standardized procedures for training and accreditation, and a dynamic process. The nurse assesses learning progression and develops an individualized care plan. So with the results of our pilot study, we have 75% of preterm baby, median gestational age 28 weeks, and median birth weight 1.1. We have 30% of these baby prematures with invasive mechanical ventilation, with central catheter, parenteral nutrition. The other group of patients are congenital heart disease, genetic syndromes, congenital diaphragmatic hernia, and other disease. And as you see, are bigger in gestational age, bigger weight. We have 2 patients on ECMO from the hernia diaphragmatic disease that were in the program of the family integrated care. We wanted to see the impact of the COVID pandemic. From the pre-COVID pandemic to a post-COVID pandemic, we almost didn't see a lot of difference in the acceptance rate, and we also saw that the mothers spend daily time, more time from parents, spend more time with the baby. Related with the family's capacitation, we saw that 70% of the tasks are done almost when we are expected, early, more or them, probably because parents are very demotivated with the program. And also we want to show which are the mitigation strategies for implementation, because it's difficult to make change in your methodology of work. We see that nursing staff are reluctant to work alongside the model. For that, we make like periodic newsletters about the progress and a feedback from parents. Very important, that one, because if they show that the parents are very happy with the programs, they feel better, this encourages nurses to work with that. Also, we have problem because the knowledge of parents about procedures generate insecurity in the professionals. This is an issue, and we harmonize and do all the adherence to the contents, procedures, and educational manuals. We also have resistance to allowing full autonomy to the parents in stacks already certified, and this was mitigated, grouping pacing in the same ward. And I don't want to go just for all of this, but we see that parents have many tasks that they want to do, and they can do it autonomously, but they were not accredited. So we make FICARE weekly rounds to see and to readapt the program. So family's opinion, that's very important for us because it's the feedback of the program. So the training materials were considered appropriate, instructions codeside were considered essential, stress and anxiety reduction were reported by all the families, and they will take again the FICARE program in 90%. And I want to read this experience from the parents. It has allowed me to meet my son. I have gone from being a spectator who does not pay anything to a main actor in the care of my child. The program has allowed me to enjoy my daughters. It's empowering to be a part of your child's care, makes everyday life in the hospital less difficult. Thank you for letting me take care of my son. And the last one that realized the problem that we have to implement things is never leave this program. Do not give up, even if there are obstacles in your way. So this is an old photograph because we are just moving to a new unit. This is how it looks in the open bay. And this is November 2022, this month. We have changed to a different intensive care unit with 12 individualized rooms, 3 for twins, and 3 boxes with 4 parents is one, and we are going to generalize the FICARE program. And just the last slides, I would like to say you that we present a family integrated project to the European Union to make implementation the FICARE program in different countries. We got a grant from the Marie Curie grant, the Research and Innovation Staff Exchange. So this is, we start in September until 2024 will be the program. It's funded by our European Union Horizon 2020. We are working with 7 hospitals, Toronto, Mount Sinai Hospital in Toronto, with a group of Karen O'Brien, OLBG from Amsterdam. Both of those have FICARE implementation program, and ours in La Paz. And we are going to work with another hospital, the Brighton Hospital in United Kingdom, Cluj Hospital in Romania, the hospital in Ankara in Turkey, and the neonatal and maternity unit in Lusaka in Zambia. So the principal objective of the program is make FICARE implementation and adapting the program to cultural and socioeconomic context. We are going to conduct a study protocol to see the impact of family integrated care versus standard care, not only in neonatal outcome, but also in the impact in families and healthcare professionals, and the impact on health economic also. For that, we are going to make many secondments from 2021 to 2024. Secondment, I will explain after the secondment what it means. The implementation strategy seems to be similar to the one that we do at La Paz. So first we have the first thing is the one that is number 1, is analysis and requirement for FICARE tailoring and implementation. This is the most difficult thing because we have to adapt the program in that different cultural resources and situations. Then we have to put all this information in online. We design a website to put all the information in the different languages. Then we have to train the professionals. Then we have to train the parents and start piloting the program. Then record the data collection and see the impact assessment and extended good practice all around. So this is a very difficult to understand. Each color, each one country. We have a country or hospitals or partners that are implementing FICR who are going to travel to the other hospital that don't have FICR, and in the opposite, professionals from other country. Now we have here 3 nurses from 2 nurses, 1 nurse, Beatriz from United Kingdom, Orsi from Romania, and Andrea also from Romania, that are coming to spend with us a time and to learn how we are doing. So there will be many interchanges. We also count with a Comillas psychology group that we have here, Amaya with us, who also are going to share all the professional knowledge with the other psychologists of the group. Just to show you some image, the 2 first ones are my boss, Adelina Pellicer, and the project manager, Santi Reyo, who went to Turkey. The third one is me, that I was in Zambia. Also is my Karen O'Brien with Barbara from La Paz, and we received sorry, I forget the name. Aflik Milene from Holland, that he came to stay in our hospital for 6 months. She is also doing the PhD in FICR implementing. This is just an example that finishes about the report that we have to do for the European Union about my secondments in Brighton, just new knowledge and training received, transfer of knowledge and training performed, and which are the research objectives. And the same from my stay in Zambia, very interesting to share all the knowledge with other people and to bring new things related from the different cultural and places. Very interesting, this kind of programs. During this year, we make some of the pillars of FICR for the program. We make an e-learning for the training staff. We make a web page for parents. We are working with all the different sites to have peer support with veteran parents and psychological support. And we are trying to improve the environment. Sometimes it's very difficult, this part, but we can look for facilities, for family rooms, and we have also the FICR whiteboard where we can use to monitorize the FICR improvement. We also have these expected impacts on sustainable development goals. I'm not going to read, but the 0 hunger related with breastfeeding, gender equality, making males more participate in the care of their babies, quality education, give that education to the families, improve the knowledge of their own baby and improve bonding, and reduce inequality, just sprout the FICR program in different economical and socio-cultural resources. So that's all. Thank you very much for your attention, and I hope you enjoyed.